Good evening, everybody. It's now 7 p.m. and I would like to start the meeting of the Health and Wellbeing Overview and Scrutiny Committee. I would like to remind everyone present this evening that we are being recorded and live streamed. And sorry, my voice, I've got a stinking cold, so I apologise to everybody. I've had apologies from Councillor Piccolo. Have I got any other apologies? Councillor Fish, just for the record, is online this evening. Right, I'd like to move to item 2, which is I move the minutes of the Health and Wellbeing Overview Scrutiny Committee held on the 11th of January 2024 be approved as a correct record. Does any member have any comments on the minutes, or can you please give your approval to the minutes?
Sorry, I just wanted
I'd just like to make one point, and to be consistent, because it was raised on Tuesday at Housing, that minute taking is now resolved, so it says member noted, member asked, member referred. There is no specific allocations of names of who asked what questions or wherever. I think it's fundamentally important that the council does do that. We did request on Tuesday that Democratic Services looked at this, and I feel it would be therefore probably sensible if this committee, if it felt so inclined, also asked why we've reverted to this taking people's names out.
Thank you, Councillor Spate. I'll take that up. But for today's for the meeting, the notes of the 11th of January, are people happy with the notes of the meeting of the 11th of January? I'm referring to councillors.
Yes, Chair, thank you.
Yes. Thank you. I've not agreed to any items of urgent business, though I would like to probably add a topic of conversation, which is appointments for people with learning disabilities for their annual health checks. Does anyone have any declarations of interest?
Sorry, Chair. I'm sure it's not a pecuniary interest at all, but I will just quote my standing interest that I do actually work for the NHS. That's all. Thank you.
Thank you, Councillor Polly. Item 5, Health Watch. Good evening, Kim, and is there anything you'd like to raise this evening?
No, thank you, Chair. Feeding during the evening items.
Okay, thank you, Kim. So if I move on to item 6, so we're talking about NHS dental services. I'd like to ask David to present his item. Okay, over to you, David.
Thank you, Chair. So I'm grateful to be here this evening. You may be aware that pharmaceutical, optical and dental services, the commissioning of them transferred on the 1st of April 2023 from NHS England that had commissioned them for basically a decade. They moved into the ICBs, Integrated Care Boards and Care Partnerships, to be the lead commissioner for those services. So I'm grateful to come and present a little bit on dentistry this evening. I'll take the briefing that we provided as read, but just would like, Chair, if I may, to highlight certain points. I think it's important to understand with NHS dentistry that the change of the contract back in 2006 meant that there was no longer registered patients at dental practices. So it's unlike GPs where you register at a GP practice. Effectively, any dentist that has an NHS contract anywhere in England, you can go and seek those services. We've outlined in the report the 17 or so practices that provide mandatory dental services in the Thurrock part of our patch, and we did a snapshot of which of those practices were accepting new adult patients and new child patients, which is outlined in the report. Effectively, nationally, there has been a problem with dentistry through the pandemic and the recovery of dental services. And the Department of Health and NHS England are making incremental steps to try and improve access. The paper outlines 1.4 onwards, one of those national initiatives, which is to remunerate dentists for seeing patients that aren't their usual patients or haven't been seen in over a 2-year period. So that's what's being done nationally, and we obviously augment that within our area. But locally, what we're doing in the ICB effectively was to commission additional activity with dentists in this area, so they could go over the 100% delivery on their contract up to 110%. So that allows them to see more patients. We've also commissioned from the 1st of April 24 onwards on a recurrent basis an additional 14,000 units of dental activity. Roughly it's 7,000 units per whole-time dentist, so it's equivalent to 2 additional dentists over those 7 practices within this area. We've also commissioned a dental access pilot, and there are 10 practices within Mid and South Essex ICB, but 2 specifically in the Thurrock area that are open 3.5 hours in the evenings beyond their normal opening time, and then they're open for sessions to patients on Saturdays 5 hours, Sundays 5 hours, and all bank holidays 5 hours. They're not just for urgent patients, it's any patients that would wish to seek those services to go and receive those dental services from those providers. We encourage people to try to go via NHS 111 to be able to get an appointment slot within those practices. So far, we've seen approaching 8,000 patients since October, additionally, of which 806, as of the date of the report, patients were from the Thurrock area. But I know for a fact we have commissioned a practice in Pitsea, near Basildon, and I know that they see Thurrock patients as well, who may wish to travel down on the train line and be seen services there. We want to keep services as close to home as possible, but by providing providers throughout the whole of our patch, it does provide that additional access to dental services. Another pilot that we've put in place was we looked at care homes, and within Mid and South Essex ICB there are effectively 8,400 care home beds in care homes. And we've asked dental practices, and we have 10 very good practices that are linking with those care homes, and they're actually sending a dentist plus dental care professionals, DCPs, into the practices to look at the mouths of the patients and to provide any dental care in the care home to patients, or where clinically necessary and appropriate, take the patient to a dental practice for treatment. That is fully signed up now. We have, as of the 1st of April, we have coverage in all areas, and the report highlights the care home beds that are being looked after within your part of our patch. We're excited about this, but we're seeing very, very different levels of care to those patients. Not in your area, but in one area towards Southend, there was a resident there who wore a partial denture, and it hadn't been removed in 6.5 years. The care home didn't even know the patient wore a denture. So we, first of all, when we inaugurated the pilot, we thought we could have DCPs, dental care professionals, go in and do the initial kind of check to see the needs, but we found as we've progressed with this pilot that we only started in November that it's important that we get a dentist in there to almost do a ward round amongst the patients to actually then diagnose what the patients needed. The idea is that that's followed up by DCPs thereafter so that they can help care home staff learn how to look after the oral health of patients, also create an oral health care plan for each resident, which is a CQC requirement. We're in the early stages of the pilot. It started in November, but we hope to gain a lot of learning from it and, of course, benefit the circa 8,400 residents of those care homes. Not within the report, but our next step is to look at children and young people dentistry and to inaugurate some pilots to support looked after children and their access to dentistry. Happy to pause there, Chair, and take any questions.
Well, thank you for your report. Thank you for your report. As a politician, I'm sure all political parties will say this, when they knock on the doors, one of the things that people say is access to doctors and dentists. Of all political parties, when they knock on doors, I'm sure. I'm really concerned about the demand. Do dental services actually know what the demand is in Thurrock? And what action plan are you putting into place to make sure that dental services for children, adults, is being met? Because when I knock on doors, I hear quite often horror stories where people are pulling their own teeth out. And there seems to be an increase in children, young children, going to hospitals to have teeth out. And it just is a very, very expensive way of delivering dental services. So can you give me, have you got any research or any plan in terms of meeting the dental needs of the population of Thurrock?
Certainly, Chair. It's a very good question, but a very complex answer. Within England, dentistry is funded, but as you know, dentists provide private and independent services to patients as well. So unfortunately, needs and demands are very different in dentistry. We find that through our consultants in dental public health that advise us that many patients who actually need dentistry don't seek to access dentistry until their teeth are wobbly, and you get the horror stories that appear in papers where they're pulling their own teeth out, usually because dentistry, effectively oral health, is if you maintain your oral health quite well, then you shouldn't get to the point where you have wobbly teeth that you pull out yourself. Access is important to us, and we're working to ensure there is access to dentists. But there are many reasons why patients don't seek to go to a dentist. Some of it is a phobia. Other is the cost, because there are 3 patient charge bands, £23, £70.70, and £306, depending on if you're a charge payer. So there are a lot of factors that make it very difficult to actually know the level of actual need as opposed to want. And we're working to understand that. As we put services in, such as the dental access pilot, we're modelling exactly what the attendance to that is, which will again help us factor what level of services we need additionally to those already provided as outlined in the paper.
Okay, so will you be producing a paper or document highlighting what the actual need is in Thurrock and what action plan you're aiming to put into place to meet that need?
Okay, again, that's part of our core work, is to understand the needs, and we work with consultants in dental public health to try to understand that. A lot of reports have been done in the past, and they gather dust on shelves, and so what we're doing is incrementally trying to increase services so that we can understand the demand, but more importantly, it's understanding the dental need of the population. Chair, you mentioned children that go for GA services. Nationally, that's a huge problem. Thurrock is not an outlier on that, but you have a high number of children that, through non-attendance at dental services, for whatever reasons, end up having to have clearances of their teeth, which is not acceptable and not right. It's almost akin to supervised neglect. So we need to work with all partners to understand that and to try to make sure that we increase access to dental services for families, for children, as young as possible. A misnomer within the dental profession until just last year was that they shouldn't see children until around the age of 2. Now there are initiatives for children to have dental checks by the age of 1, and even before teeth present in young babies and children, to have the parents, their carers, take them into practices so that they can get used to seeing a dentist, so they effectively have a lifelong relationship with a clinical professional that can see them clinically appropriately at whatever periods to make sure their oral health is correct.
Okay. One question will go. And you came back to me and actually gave me 4, of which we found that only 3, 1 could actually provide that, and the other 3 had run out of NHS money to provide dental care. Is there any learning from that?
I think it's important to recognise that dentists will see patients as they deem clinically appropriately. And so many patients that would want dental services don't actually need dental services at times, and many that don't wish dental services actually need dental services. As outlined in my emails to you, Chair, practices can open and close their availability to see patients almost on a daily basis. So even the 17 practices that are outlined on the report that we drafted, saying that 7 of them were taking on adult patients, I'm sure if we checked tomorrow, that would have changed. It would either have gone up or down, depending on their clinical ability to see patients. We did commission 10% extra UDAs with practices, and many of those 17 practices have taken that on board so that they can see additional patients. And then on top of that, we've commissioned an additional 14,000 UDAs, 2 whole-time dentists in this area as we go forward into next year.
Okay, I don't feel confident, I have to say. I'll leave questions to other members. Councillor Polly? Oh, going to go Councillor Fisher and Councillor Polly.
Yeah, there's a lot of pilots mentioned in what the person had to say there. And so there's a lot of potential to improve the service and access to the service. I know this is the last meeting of the year, but I would hope that there'd be another opportunity to hear how the service is progressing and how the pilots are working out.
So, Chair, if I could come back on that statement. Yes, absolutely. The pilots run for 18 months, and we will do an evaluation at the 6th month and 1 year period, and we would happily come back and report to this committee on what the findings are and how we're flexing those pilots to meet the needs of the local population. Thank you.
Thank you. Thank you.
Councillor Polly?
I'm quite alarmed to hear about the poor oral health within the care home situation, because obviously poor dental hygiene or oral hygiene leads then to other potential bacterial infections that then can be quite severe in people of older years. So that piece of work I very much welcome, and obviously a lot of these residents within the care homes don't have advocates, and that was a very interesting and very welcome piece of work. With the children side of things, it's education, isn't it? It's about not just brushing your teeth. It's about your diet. We've talked often about obesity, too much sugar, even fruits to a degree. I mean, apples still have acidity in them if you have it. So part of trying to get that still perplexes me that you're having babies in at 1 year old to a dentist. I get the familiarisation, but is that also to start the education side of things? Would that be fair?
Yes, a very fair comment. The idea is to get a family in with their children so that the parents, carers can understand about oral health. You know, toothbrushing twice a day, morning and evening, not drinking high sugar drinks, especially late at night, etc. Because dental disease is almost entirely preventative if we look after, you know, the oral health of our children and our families. So a lot of it is prevention, even down to fluoride varnish that a DCP can paste onto a children's teeth that will help prevent cavities and decay. But a lot of it is preventative as well. So our plans with regards to children and young people dentistry that we're in the process of working up at the moment, we will inaugurate pilots that will help not only in the prevention but also in the care for children. But key to it is to have the child attend a dental practice and be comfortable at doing that, and then be recalled appropriately under nice guidelines, clinically appropriately throughout the rest of their life, but also brushing their own teeth. One of the learnings we had out of the pandemic, where there were reasonably orally healthy patients prior to the pandemic, and really it was the dentist that was keeping their oral health going, and when they didn't attend for circa 2 years over that pandemic period, they came back and their oral health wasn't very good, because the part that was missing was the patient, the individual, looking after their own oral health.
I'm just thinking about the ward where I live. I've been recently talking to other healthcare professionals within that area. A little bit in alignment with what the chair's just asked. I'm aware of a practice that is looking to facilitate a dental surgery within their building, but they seem to think that how do they approach the ICB? Who decides whether the dentist can take up residence in a certain area? Is that, if it's a private clinic, I presume that's a totally commercial decision, but if it was for NHS patients, a bit as the chair was asking, is there a criteria if we know there's an under-provision of a service in an area, then that would obviously add more weight to their request to start a new surgery up. Would that be fair?
Yes, that's a very fair comment. Most dental practices are a mixture of private and independent dentistry, and they deliver also an NHS contract. That's mostly the model. In terms of the commissioning of dentistry, we commission with known NHS providers. If there are other providers that want to provide dentistry, my name and contact number and email is at the bottom of the report that we provided. just give them my details and I'd happily talk with them outside to see any possibilities.
Councillor Spate.
Yeah, thank you, Chair. It was just a little bit of additional information, if I could get it, from the table in your report, David, where we've got 1, 2, 3, 4 dentists who it says not stated, so we don't know, presumably, what the position is there. We've got ones where it just says no, and again, that's not really very informative. I mean, is it a no because they're absolutely rammed with the maximum number of NHS patients that they can get and therefore they can't fit any more in? Or is it a practice policy that they don't take NHS dentists? I think that additional information would help us build up a picture of where, you know, so if we were drawing a map of the borough, it would help us see where pinch points are. It's not particularly informative. So I don't know whether you would want to particularly go, or even if you could go through and say what they were, but I just think when we're being given information, you know, it really isn't very informative as it sits at the minute, and certainly doesn't help me build up a picture of, as I say, pinch points, areas of the borough where there is a clear deficiency. So I just think for future reference, when we get information like this, and because it's supposed to be an update on the exact position in the borough, and it really isn't. I don't think there's a question in there really, but you might wish to comment.
Chair, if I may comment, as clearly stated in the report, that was a snapshot as of that particular day. The report outlines the 17 practices delivering mandatory dentistry. Where it says not stated is that's the practice have not done what they're now contractually obliged to do and updated their NHS website to say whether they're accepting adults, whether they're accepting children, or whether at this point they're not accepting new NHS patients. And it varies for very many reasons. If they say no, it could be that they have a full list of patients that they'll be seeing in the next 6 weeks, and so a patient will know not to contact them because there's not availability there, but they'll have a very big list of usual patients that they see as NHS patients anyway, all of these practices. So this is just a snapshot in time, and we're working with the practices where it says not stated, because as of late last year they became contractually obliged to update their status every 90 days. So we contact them to ask them to do that before we then start to go a more contractual route with the provider. Thank you.
Councillor Tandy.
Yeah, just a quick question, whether it's true or not. I've heard from a few people as well. Each practice, does it have a budget? And like obviously the financial year starts in April, so the NHS give them a budget. Come end of the year, well January, February, March, the dentists normally turn around and say they've got no appointments. Is that the reason because they have no more money left? Is that correct or not?
In some instances, yes, but the contract does require them to deliver their contract equally throughout the year. So those that are on a higher run rate and will run out by January, February, March, they will contact us and we'll give them permission to, as we've done on a blanket form, to deliver additional UDAs where we feel that they're necessary. So we'll work very closely with practices to understand their run rate, but they're meant to deliver NHS dentistry across the whole contractual year equally. We found that some of the practices that are on the dental access pilots, they claim UDAs for the evenings and weekends as well, and they're on a very high run rate, and we've had to commission additional activity with them so that they don't run out, because they're seeing many more patients this year than they've seen before, because we've commissioned that dental access pilot with them.
Councillor Spate.
Sorry, Chair, I was going to, but Jimmy was leaning. I was just going to sort of follow up on my other question. David, I wasn't overly overwhelmed by the answer, and you mentioned that as of last year, at whatever point it was, I think you did say late last year, they were contractually obliged to do certain things. Well, the statement, this was put together on the 26th of February this year. So I don't understand, given what you've said about the fact that they're contractually supposed to have this information available, why it's not available on the document that was put together on the 26th of February this year.
It's to do with the 90 days. So 90 days ends circa the end of March. So if they haven't updated their status by then, at that point we can contractually speak to them and require them to do it. Whereas within that 90 days we cannot do that.
Kim.
Thank you, Chair. Can I ask a couple of questions? Yeah. So obviously you've explained about the 90 days. So I'm from Health Watch, so we do know that there's a 90-day turnover, and we do know that it changes day to day. So we have a whole host of volunteers that mystery shop regularly, phoning all of them to find out who's taking anyone and who's not. Most of them will say things like, our list has been closed for 2 years. We can't take any new patients. Some that are taking children will only take the children, providing the adults sign up, the parents sign up as well. But the parents are telling us they can't afford to go to the dentist, but they need to take their children to the dentist. So it really does seem to be a bit of a play on it. You know, one day they can and then they can't. But that's no good for people who are desperately trying to get their children registered. The 111 emergency is really good, which makes it really difficult because people will go, get treatment for that moment for an infection or whatever, but it's never going to be cured because they can't get a dentist. They come away and then they're back through 111 to go back again for emergency, which must cost an awful lot of money round in that circle and a lot of unhappy people and children. But one thing you didn't mention, which I think is really good, is the new project for the children and young people with the supervised toothbrushing. So that's going out across, and we've helped the two girls that are running it into all sorts of places, into the all sorts of places where there are children and parents. But we found ourselves that parents will say that they didn't think they had to take their children to the dentist until they got their second teeth. Some of them say they didn't even think they had to brush their teeth while there was only baby teeth. So that is a big education bit. But while they're going out doing this fantastic programme and they capture all these people, they then can't get registered at the dentist. So although they're giving them toothbrushing and giving them the means to, it just seems like everybody's running around in a big circle without actually getting much treatment for anybody. So I think it really is a big problem, and we chase them up for their 90 days. Well, you told us that 90 days ago, so what's your 90 days now, what are you saying? And they don't much like that. Don't like us asking them.
Chair, if I could come back. We need to work very closely with you as Health Watch so that we understand what you understand on the ground with patients, and we need to understand which of those practices are being less helpful in terms of seeing children, because yes, absolutely children should go to the dentist and have a dental check by 1 year of age. Supervised toothbrushing programs that you mention are wonderful. We need to understand their benefits and then scale them up as we go through a pilot for children and young people dentistry. But the key to me is being able to get then the children, not only parents, educated to understand that children need to brush their teeth twice a day, but also that the children go for regular clinical checkups by a dental professional.
We record it monthly. We do mystery shopping every month, so I'm more than happy to forward that to you, just to see where we've got.
Thank you.
Councillor Polly.
Just coming back on the pay structure for dentists, so dental practices. So we talk about a UDA, so, and I noticed in the report that that's how it's all broken down, and you said we've added that extra capacity by allowing them to go to. Could it, Could there be a situation where a larger organised set of dental practices buy up some surgeries and then contract it out to dentists so that that unit price gets broken down, so the person actually delivering the services doesn't get the full money that's allotted by the commissioning service? Is there any room in the system to allow that to be misappropriated at all?
So maybe, Chair, if I can explain a little bit. So if a contractor holds an NHS contract, they'll be paid X amount per year, but they're paid in 12ths, so every month. And then for that contract, they deliver units of dental activity. That's the beans that are counted. If you go for a band 1 course of treatment, which is a checkup, the dentist effectively ticks 1 unit of dental activity off their tally. If you go for a band 2 course of treatment, which is fillings, extractions, they would tick 3 UDAs off their total. Or if you go and you need any dental services that require lab work, such as, I guess, dentures, bridges, they would tick 12 units of activity off. And it's reported through FP17s, through clinical systems, and the Business Service Authority balance it for us. So there's very little wriggle room for them to be unscrupulous. And then we have colleagues in Eastbourne who look clinically at what the dentists claim and make sure that it's appropriate and they check for outliers, etc. But you have to remember that dentists are GDC registered. They can provide private and independent dentistry and charge whatever they wish to charge for it. The NHS contract remunerates them for an annual contract value for so many units of activity. But they can have other performers that, as long as they're on the NHS performers list, deliver that dentistry on their behalf. So it's not uncommon for a dentist in this area to ask for a performer to work for them to deliver their NHS contract, and they may pay that dentist £14 per UDA, even though the UDA is worth more than that, because the actual contract holder has all of the ground payments, the running of the practice, dental nurses, etc. So it's quite a complicated kind of background financially. I would happily outline that in a discussion with you.
Okay, Kim, I can't wrap this up soon.
Thank you. I forgot to ask you earlier. So we've had a few people contact us with bariatric patients in Thurrock, and a couple of them go to the same dentist in Tilbury who can't treat them because he hasn't got the setup to. But there is a bariatric service within Thurrock, which is in Grays. But he's saying that if he refers them to there and they don't take them, they're getting no dental service. So can they just refer for treatment but stay on that list, or do they have to change and take a chance that they're going to get taken on? Because it's a bit of they're stuck in the middle now.
Certainly, Chair. So because there's no registration at a dental practice, you're only a patient of that practice while you're in active treatment. If it's appropriate that the patient needs to go to another dentist that has a bariatric chair, then of course they can do that, and they shouldn't be disadvantaged by doing that.
Okay, Neil.
Thank you, Chair, for allowing me to speak. Just a quick question around people with learning disabilities, and particularly our friends with autism with challenging behaviour. We used to have, pretty good support, but it's very hard to get that now. Is there a specific part of the contract that you allow for that in terms of extra time and patience that's required? Because otherwise we end up in hospital and obviously upsetting and expensive.
Excellent question, thank you. So towards the end of the report, I mentioned CDS, Community Dental Services, and they deliver special care dentistry, and they are remunerated for lots of additional chair time, and they would see patients with higher needs. whatever those patients are. The good thing is, with our care home pilot, CDS CIC, who are the community dental services, used to be the only real providers of domiciliary care in care homes. And they've found that their list of patients has gone down by 50%. So they're able to focus patients in the community more that have special needs and need that extra chair time.
That's really brilliant, David. And of course, they're a community interest company like us, so not for profit, which is interesting that they're able to do that. That's really good.
Okay, thank you very much. Can I make a request? And I hope I'm not out of order in making this request. Is I really would like to see a plan based on the need of Thurrock. I understand how complex that may be, and how that need could be potentially met, because I feel there's a shortfall. Speaking to the people, there's a shortfall in this service. I'm very concerned about children. I agree with Councillor Polly and other people that have spoken. Education is massively important. I know it's a wide subject, but I really would like to see a service developed upon need of the community. Does that make sense?
Chair, absolutely. All of our commissioning is based on need, as we are able to understand it.
So I'd say the needs is struggling to meet the needs of the community. Okay, so therefore I'm saying, well then can I have a plan to actually meet that shortfall in need?
Chair, we're in the process of developing a dental plan across the whole of the ICB, and of course Thurrock is a very important part. You'll be figured in that plan, and we'll happily discuss that with you and share that with you as we move forward. The key to it is really to actually commission the services though and get them in place, and not spend our lives just planning.
I get that. So can I request that under our new structure of people, that a report comes back to people sometime next year on a plan to meet the needs of Thurrock in particular? We're here for Thurrock today, so would you be happy to do that?
Chair, more than happy to do that. And the plan, it'll also not be a plan, but it'll augment and show what we're putting in place to meet the needs of the population.
Thank you very much. Thank you. You're happy to stay or free to go, David? It's up to you.
If it's all right, Chair, I'll go home to my family. Thank you
for your time. Right, if I move on to item 7, which is an update from Mid and South Essex Trust. So I'd like to ask Fiona to present your report.
Thank you, Chair. So in your pack, you'll find our updated report, just to take you through some of the highlights. So we've included an update on the impact of the industrial action, which continues to be a significant challenge for us. The year-to-date totals of that impact and those associated with the most recent round of industrial action are included in the pack. We share this information regularly alongside the financial impact of managing the hospital through the strike periods, with our regional and national teams on an ongoing basis. At this point, we are not seeing any green shoots around resolutions, so whilst we are in planning for next year and planning without industrial action, we are expecting to continue to have to manage through those impacts until there is further discussions nationally. So we did continue to see an impact to our cancer-related appointments. As with previous, we've managed to restrict that to about 10% of the planned cancer activity being lost, but that does result in delays to individual patients, regrettably. around our urgent and emergency care standard or services. So this continues to be an area of ongoing pressure. You'll see in the pack that our 4-hour delivery standard continues to improve, albeit not where we would want it to be. The figure in your pack is for the January standard, and we continue also to improve in our ambulance offloads. So we're working to an ambition to hit 90% of all of our ambulances offloaded within 30 minutes, improving up to 77% in January. Just last week, it was around 86.9%, so that we really are seeing sustained improvement in that area. But our ED and our hospital continues to be significantly congested. So we have ongoing work around that. Our 4-hour standard, so the number of patients, as you'll know, that are seen and discharged or admitted within 4 hours is also improving, but again, not yet where we want it to be. We're currently about 70%, aiming to hit 76% by the end of this calendar month, March. Just to pick through, so in terms of cancer, we do see about a 2-month lag in the way that our cancer statistics are reported, but again, we do see a continued improvement. Our target for the end of March is to hit the 75% faster diagnosis standard. You'll see that the last reported month was 62%, and we monitor this on an ongoing basis, and last week it was at 71%, so a lot of work to do done, but still more to do to get to that 75% again for the end of March. Waiting list figures are presented. I think there's a couple of things I'd like to highlight. So a lot of the pathways with waiting lists are heavily reliant on diagnostics. So we are improving our activity and capacity in the diagnostic services. The temporary endoscopy unit at Orsett has opened in February, and we've seen 465 patients through that unit already. To support us to deliver what we need to in diagnostics in permanent facilities, we continue to press forward with our community diagnostic centres. So I believe although the spades in the ground ceremony for the Thurrock CDC is not until the end of next week, work did start in January. So we are on track to open this year. Some of the benefits of that work will be released before then as services reorientate, and the update today was that from April there'll be an additional 225 phlebotomy appointments available at Thurrock as the service transitions across to Nelft. So that's positive for the local population. We've got a really important piece of work that will be coming to colleagues around the table and beyond as we work to develop a 10-year strategy for the organisation, for the FT, in alignment with the system strategy. So I'm sure that we'll come to you with an offer to talk to you some more about that in the coming 3 to 4 months. A couple of highlights really, I think. So our local CTC at Basildon, one of our teams has developed an app that allows for remote monitoring of patients with irregular heart rhythms to allow them to be picked up and treated, and that's been such a successful project called FibreCheck that they've actually now been listed for a global award, so hopefully they'll be successful, but I think it's important to celebrate the achievements of the teams. And just some highlights in the pack around the good work that's ongoing around apprenticeships. We're really keen to continue to engage with both Thurrock Alliance and Basildon Brentwood Alliance around our responsibilities around as an employer to support employment for our local populations. So just a couple of other things. So I understand that Alex isn't here today as our Alliance Director, but she did have some feedback around some queries that were raised previously. So we have confirmed that it is the same cost for phlebotomy, regardless of the provider. And see that it's not in the pack, but there was a phlebotomy paper submitted. So I've got that, and I can just pull out the Thurrock highlights if you're, because I know it's an ongoing issue for us all. So one moment. So currently, we continue to deliver as the FT. We continue to deliver phlebotomy in Orsett through Pathology First. Our current wait times at Orsett are at 9 days. At current Corringham, they're at 2 weeks, and at South Ockendon, they're at 5 weeks, 35 days. The issue with the South Ockendon service is that it's only operational 1 day a week. We have now got the clinical capacity in terms of phlebotomists to open further capacity there to address that, but unfortunately there's no available space in the health centre, so we continue to seek space in the health centre. Alex and her team continue to engage and work with GP providers to increase the uptake of the LES for phlebotomy, and as I understand it, we now have 3 people who have volunteered. We had a discussion around can we look at volunteers to support patients in this service, and they now have 3 people that have stepped forward that will be going through training. It will take a couple of months, and we'll equally have to find chair space for the bleeding for those patients. So continues to improve, but still more to do. And then lastly, from that paper, there have been some concerns raised in the system around paediatric phlebotomy. So there's been some specific actions that the teams have been undertaking to support that position. Predominantly, they've been proactively pulling patients forward from the following day where capacity is freed up through DNAs in the service, and patients over the age of 11 are being moved into adult slots so that the young, difficult to bleed children are prioritised for the service, and that's allowed for the wait times to come down from 6 weeks to just over 2 weeks. So ongoing work there also. I do note that we have got an outstanding query around the bids for capital support that the FT has put in, and my Director of Estates and his team have been working on that. It wasn't quite the quick turnaround piece of work that they anticipated just because of the way that the records are held, so he's requested that he comes back to committee himself in person to present a paper to update when we next meet.
Thank you, Fiona. Can I ask a few questions? Cancer's been a bit of a concern throughout the year. I'm glad to hear you think you'll make 75%, which is the minimum standard, by the end of March. That's good to hear. How are you going to ensure we can maintain 75 and above?
So 75% is the current national standard. That's what we're aiming for. We're not yet in receipt of planning guidance in terms of national directive further than that, but we are anticipating that we will be working to go further than that through next year. That obviously is linked to whatever funding is made available to enable us to create capacity to keep going further with that, but I would expect that we will be looking to some interim in-year markers on that to not just sustain that but improve it further. I think in the pack there's some feedback around the over 62-day backlog number, which has been another area of challenge, so not just addressing getting a quick answer to patients, but getting them quickly through treatment where it's required. And that's another area that we are seeing significant improvement in. I believe in the pack there's a figure.
I'm going to ask you, Fiona, what the standard was from referral to treatment
Referral to treatment is
within 62 days. What is the standard the government sets?
So for referral to treatment for 62 days is 92%. 92%? Yeah.
Is that changing at all? Is that remaining 92%?
There's a little bit of ongoing discussion in terms of nationally and the cancer standards and how they're going to be measured going forward. Our focus has been on significantly reducing the post-pandemic backlog, which at one point was over 2,000. So, yeah.
And what's the trust sitting at the moment in terms of 62 days?
I don't have the live position around 62 days. We monitor weekly around our FDS and our backlog numbers. So our backlog number had dropped from over 700 to 540 this week. So I don't have the live monitoring for where we are around 62 days, but I can provide that back to you.
Okay, if I go to councillors first. Councillor Fish, do you have a question?
I just wanted to say that I didn't hear much of that report because there seems to be a problem with the signal. As Fiona was talking, the sound kept on breaking up, and my picture is breaking up as well. So I wonder if somebody could have a look at that, see if the signal is as good as it could be. Thank you.
Thank you. We're looking at that now, Councillor Fish. Councillor Polly?
Sorry, Fiona. In this report and previously, it's been said that there is capacity at the South Ockenden Health Centre to pick up some of the services that should have come from the IMCs. But we're just hearing that we can't put another day of phlebotomy services into that building because there's no physical room. So I struggle with that. If we on a Tuesday morning, and I've used the service, I know exactly where the room is that the where you go in and have your blood test done. That's not even one of the rooms that has been identified as extra capacity. So, and it's not being used by the children's services or so. I don't. If we've got the clinicians available, and I know that the physical room is there, well, why can't we put somebody in there on a Thursday? Has been suggested. I've just wondered what I'm missing. Sorry.
Thanks, Councillor Polly. That's a very fair question, and that's a question that I've been working with Alex on over the last couple of weeks as our Alliance Director, because when pathology first have gone directly to the health centre, they've been clear that there was no potential for additional access. So Alex is linking in with them and talking to other providers that use space in the centre to see how we can adjust the utilisation to create that capacity. But yeah, I don't run the health centre, so I don't have the answer to that, but I am working with Alex as our Alliance Director to see what can be done to resolve.
Sorry, Chair. So coming back, that could be just a case of somebody being there with a set of keys to open up. Because it's suggesting that part of that building is used is not open sort of every day, Monday to Friday, but on a as and when basis. So, sorry if I misunderstood. I don't think that's answered my question. We know there's a physical room there. Why can't we get access to it?
Sorry if I wasn't clear. So the health centre have told us that they can't provide the capacity to the phlebotomy service, that they don't have space for it. And so I've been working with Alex as the Alliance Director to work with the Health Centre to understand where what the utilisation is like within the health centre, to see if there's any flex in that response. Is that clearer? Sorry.
Yeah, it's just on that note. I know we've raised before. I know we may not be able to answer, Fiona, about services like phlebotomy being available in the evenings. I know that's something we talked about in terms of Corringham. I know that's something I know they're going to be looking at. So maybe is this a question more for Alex than for yourself?
I think it may well be, although I've been shared the headline number around the expansion of the phlebotomy service at Thurrock Community Hospital, for example. I don't have the planned hours of service available.
Councillor Spate?
Yeah, I have a couple of things, and sort of I'll put them in a different order to what I was going to ask them. Following on from Councillor Polly's questions, it appears that the thing at Ockenden is a room, an availability of space. As far as I can ascertain from the answers that you've given, it's not about personnel. I just find it really amazing that today I and many hundreds of other Thurrock men have trundled along to Impulse Leisure at Blackshots, and I do mean hundreds of men. Good. And we've all had our various jabs and our blood taken throughout the day by some very good people. A most painless extraction from me, even if it was in the back of the hand. Very, very good, very well run. And I just find it incomprehensible that we have this horrendous backlog, for example, of 35 days, that we just seem incapable of thinking outside the box. And because there isn't a room available at South Ockenden, we allow the numbers to stack up. It must be within the capacity of the skilled people that we employ within the NHS to organise, let's call it a pop-up blood testing service or whatever you wish. But, you know, you can't say it can't be done because it's been done today. The staff who took the blood today must be available to take the blood and get paid. They were paid by chaps today, but they'll probably be more than happy to be paid by the NHS. But we just do not seem to be looking for solutions. So can I ask that the Trust does try and think outside of the box? It looks at what other organisations are doing. It looks at what is available within the borough to try and put it together. Unless you can tell me any particular reason why pop-up phlebotomy doesn't work.
Thank you. So I'll certainly take that away and have that conversation with Alex. So in terms of the commissioning of services and the range of providers that are out there, to see where that improved access could be generated. Obviously, we've discussed previously the training programs and the recruitment that have been ongoing to create the skilled staff pool that was a deficit. We're now at a position where that's significantly improved, and we are working on the remaining space challenge that is has popped up in that particular locality, and I believe that we will find a solution to it. Meanwhile, we need to continue to improve the waiting times across the other areas also.
Councillor Spate.
Yeah, and my second question, and it goes back and it reflects what the chairman mentioned when he was speaking about dentistry earlier. We're here to represent Thurrock this evening. Thurrock is our priority. And we've got a presentation of statistics from the Trust today, which are informative, don't get me wrong. But if you go to break them down, it's impossible to actually ascertain what the position of Thurrock is in all this. And we talk about 3 different hospitals, and I do accept that patients from Thurrock get treated at Broomfield, they do get treated at Southend. But for the sort of the run-of-the-mill things, it's Basildon. A&E is Basildon. To a large extent, or that's the perception. It may not be the reality, but that is the perception of the people through. So I'd just like to ask that if going forwards, when we see statistics that we get a breakdown, because, you know, the trust statistics is a huge geographical area from the other side of Chelmsford to the coast at Southend to Purfleet. It's a monumentally large area. And Thurrock, we do have a sense maybe we always look for the negative rather than positive, but every time we do see statistics about Thurrock, we're at the bottom end of it. And my suggestion would be, and if I'm wrong, I will apologise, that some statistics will be a lot better in Chelmsford and Southend, and Thurrock, as usual, is getting the rough end of the stick, and it's been disguised because we're seeing a trust-wide set of statistics. So I just ask, very politely, that when these reports are shaped going forwards, we can have a focus on statistical analysis of Thurrock.
Happy to do so ongoing where possible. We don't currently monitor, for example, cancer is monitored through a shared PTL across all sites. We monitor access to diagnostics by locality because they're delivered by locality. But just for reassurance, the highest performing hospital in the trust on the UEC standards, including ambulance offload and 4 hours, is Basildon Hospital.
Thank you, Fiona. Can I go, Councillor Tandy, and then I'll ask you.
Yeah, I went to the local doctors. I saw a little sign on the counter saying about Allsit Hospital taking 50%, walking 50% online. Is that a new thing, or has it just changed? I presumed it was 100% online for appointments.
No, there is a walk-in service available at Allsit. We actually adjusted the proportion of appointments that were available as walk-in after discussions at this committee to increase that to support immediate access for particular patients on cancer pathways who may need very rapid access to blood tests.
Could you tell me what percentage change it was?
At this moment, no. I can't tell you what the relative adjustment was. And I know there was an increase in capacity at the same time, so I wouldn't be able to give you that information directly today, but we can provide it.
Obviously, we're talking about strikes. Is there any future strikes planned by the junior doctors or doctors you've heard?
At this point, there has been no notifications received. We usually get notification about up to, it can be as little as 2 weeks in advance. And yeah, so we may expect to see something in the upcoming Easter break announced at some point in terms of if we assess the patterns of how things have been distributed over the last year that we've undergone.
Okay. Thank you. Ian?
Thank you, Chair. It was just a comment that actually relates to Councillor Spate's last question. So, under the section discharges from hospital, the final bullet on the top of page 19 talks about, you've written, there are ongoing efforts to improve discharge rates with senior staff in each site conducting weekly patient reviews. However, challenges remain in community and social care. I'm assuming that is across all local authorities and the trust as a whole. In terms of the discharge arrangements in Thurrock, I think we're exceptionally proud that we have virtually no delayed discharges. We, unlike other local authorities, have a dedicated discharge adult social care team in the hospital. And I think the last national data I saw concluded that Thurrock had the 5th lowest rate of delayed discharges in England over the last 12 months. So if you could just clarify that, that's generally across the trust rather than relating to my department.
Yeah, happy to share that in relation to patients that are discharged from Basildon Hospital. Our social care, so our Pathway 1 discharges from Thurrock are the lowest, or are not an issue. We do see pathway 2 and 3 delays fairly more evenly distributed, but the rapid response and support in relation to pathway 1 discharges, so those that are for patients that are going home with social care support, it's not a presenting issue as it relates to our Thurrock population, but more so in other locations.
Thank you.
Okay. Just a couple of things of note, really. I'd like to thank Councillor Cockshaw for writing a letter. We've wrote a joint letter to Lord Markham regarding trying to get some funding for key repairs for Basildon and Orsett Hospital, which we're hoping to get a response from soon. I've also made a request for information about people being discharged too early, potentially from the local hospitals. I've come across a couple of cases recently where people have had to go back into hospital after being discharged within 48 hours, 3 days after the original discharge. So just a concern I actually have. I'm awaiting that report, and I'm gladly share that with members and others once I actually receive that report.
I've just realised there was one brief update that I omitted to share. If I can take another minute of the committee's time. We did have a discussion last time around the intermediate care beds consultation, and I was asked to just be clear around what that means for our Thurrock population. So during COVID, we had some changes to the configuration of stroke beds and intermediate care beds as we increased bedded capacity across the system. And there is a consultation out at the moment which relates to how stroke and intermediate care services, as they are bedded, are going to be provided for the future. So I just wanted to confirm to the committee that both of the proposals going forward include the retention of the Thurrock intermediate care beds at the Mayfield unit of 24 beds. There will be a potential change to the configuration of the Brentwood beds, which is currently housing intermediate care beds on Thorndon and stroke rehab beds on Bayman Ward. There's a proposal that outcomes are best delivered in a centralised location for stroke rehab. So the two proposals going forward would see either all stroke at Brentwood or stroke at Brentwood and where it's currently delivered at Kick in Rochford. Should the centralisation happen at Brentwood, the IMC beds that are currently there will be delivered at Mount Nessing Court in Billericay. So there is an increase in the overall capacity for the whole population, and the Thurrock beds will continue to be prioritised for Thurrock patients.
Thank you. Any further questions?
Yeah, well,
Councillor Polly?
yes, thank you, Fiona. As I stated before, I am appointed governor, and there was a presentation this afternoon at Basildon about the closure of St Peter's and then the ongoing, and that I think you've just answered one of my concerns, because I think the stroke consultant from Broomfield was there's an option A, option B, and it was 50 beds, as you say, at Brentwood, or 25 stroke and 25 integrated, and that was the thing that gave me a concern, because when we do have pressures, when we have the winter pressures, would those beds be ring fenced just for stroke survivors or stroke rehab, the whole 50, which would mean that we as private residents would lose 25 or potentially 25 beds from Brentwood. You know, currently I've got an 86-year-old resident that's having to drive herself. We're working on that, but to Basildon and back, if we're then going to start sending her to Halstead or further afield, that would give me a big concern. So that's what I know. I know the presentation we had today was their preferred option would be option A, to deliver then a centre of excellence, and either in the bigger picture to get to a stage where they could actually deliver thrombolytic procedures there. If that, so we would end up with, so not just the thrombolisation that we see in the EDs, but end up with a neuro base there, a bit like Queen's, or and that just really worried me, that the community hospitals are very much relied on by the acutes for step down. If we can start turning them into centre of excellencies and make them just focus on a specific discipline, then we again are losing community beds, which puts more pressure on adult social care, and we're getting residents that are going home. I know there was a policy, wasn't there, that 72 hours from discharge then for packages of care to be put in place. I think Southend brought that in, but we know that then families can't cope, or that person can't cope with being home without those services being put in place. And I have no concerns about the care that's given at the acute stage, the hyper-acute stage of the stroke service, but it is that follow-on that I really am concerned about.
Yeah, so just to confirm, the capacity will increase slightly for stroke on either model, so that we can kind of enhance the recovery model, and that's why the stroke service do really feel there's a lot of benefit of having all of those stroke rehab beds located in one location and creating that focal point for the high-skilled professionals that you need in order to be able to get these patients optimally rehabilitated, and get the best outcomes for them. But in terms of our intermediate care beds, there's a clear plan to retain the right capacity within the locality. So whatever the outcome of the consultation, we'll maintain the level of intermediate care beds that we need, and they won't be given over to stroke. The increase in stroke capacity is additional beds.
Thank you, Fiona. Do you want to move on? Oh, sorry, Kim. My apologies.
Fiona, can I just ask a question about the diagnostics part and the CDC? So I was always under the impression that we were going to get the endoscopy unit in the Thurrock CDC, but today at the presentation at TICA it was that it's not going to be here in Thurrock, but the mobile one is in Allsit at the moment and has seen 465 patients since February. So why is the decision, or do anybody know why the decision was made to suddenly not provide that in Thurrock when it was on the original, and obviously there's a need for it?
Yeah, happy to take that question. So we've been doing a lot of work over the last 18 months with the National Endoscopy team, and they are very clear that small units do not deliver the best outcomes for endoscopy, so they're not the safest clinical model, and they are driving very hard nationally to create a critical mass when we create an endoscopy centre. So much so that we will only have one community diagnostic centre delivering endoscopy in the whole of the Mid and South Essex patch, because the evidence is so strong that that's the way to do it. The national team are the ones that drive that clinical strategy and who make the funding decisions. So we had originally put forward, in line with their guidance, to create the 6-roomed unit at Pitsea, feeling that that was a location that kind of balanced a lot of our access challenges across such a big footprint. We're now been given additional funding to create 8 rooms in that unit at the CDC in Pitsea, because that will give us enough capacity for a 10-year kind of forecast of where endoscopy demand is likely to go. There's always that balance, isn't there, between local access and actually what's the most effective way to deliver a clinical service, and the national drive is to create community services at scale. We're hoping that the Pitsea location will be, a reasonable compromise in that. And the ORSIT unit is much like a lot of the other temporary diagnostic units that are scattered around the place. You'll have seen CT mobiles, MRI mobiles located around the place as we continue the development around CDC to create those facilities in permanent locations, and that's part of the interim solution supported by national funding. Maintaining that level of a service in an off-site location wouldn't be supported with funding nationally because it doesn't align with the clinical model.
I'm a bit surprised, bearing in mind the population it serves. Is that likely to be reviewed at all? Could it be reviewed?
In terms of...
I'm actually thinking of a location around one place. Just doesn't seem to be enough for the demand of people.
So we've got quite detailed modelling of what endoscopy capacity is going to be needed across the next 10 years, factoring in lots of changes, including expansion and age range scope expansion in the bowel cancer screening programme, etc. So there's a lot of work that's gone into the modelling in order to secure the support and the funding from the national team. So that won't be the only endoscopy facility, and that the hospital units will still continue to run because there are procedures that can only be delivered in the acute site also.
Okay. Okay. Councillor Spaten, I'll need to move this on.
Sorry, I made me said. I think you just said that because of the changes that have just come in, you were looking to take 8 units, 8 rooms now at Pitsea. Is that right?
No, so we had put forward a proposal to build a 6-room unit at the Pitsea CDC on the guidance from the national team that we should only have a plan to have 1 and it needs to be big enough. And through that work and the modelling, it was suggested that actually we would need 8 units by 10 years from when 8 rooms from when it's built, and that was the preferred model of delivering that capacity in terms of the clinical steer.
Yeah, I was just interested in the timeline. We'd sort of got something in Thurrock, and that just appears to have changed just now. And I'm just wondering where you've just said you went from 6 to 8 at Pitsea, and I'm just wondering when that decision was made.
So that was on the advice of the national team, probably about 4 months ago, to adjust from a 6-unit room plan to an 8-room plan.
It's just that when you sent press releases out in May last year, you said 8. So you were talking about 8 last year, and you've just said you've gone to 8. I just sometimes wonder whether we can believe what we're told.
I'm proposing to move on now. Thank you, Fiona, for your report. Really, really helpful. Right, can I go to Councillor Cockshaw, please? Thank you for your report, Councillor. I'm not expecting you to go through every item of the report, so if you just give us, I'm assuming councillors have read your report, if you want to just highlight some particular points and take some questions.
Thank you, Chair, and thank you for committee for giving me the opportunity to actually present some of the amazing work that actually does go on within the department. I'm sure members will be aware of some of the agenda we're actually trying to push here in Thurrock. I'll start, just really want to point out some of the work that we've been doing with Better Care Together strategy, actually talking about how we transform to new models of care, especially for social care and health. We're really moving away from that crisis-orientated method of immediately time, task, but actually looking at how do we create bespoke solutions that are actually designed for our residents, but are actually addressing their needs rather than just ticking a box as an exercise saying we've completed this. We want to actually co-produce and actually co-commission services that actually our residents need and services they want. On that note, I really want to just say the work of our social workers is absolutely brilliant. The work they do is absolutely amazing, and actually in Thurrock, I think it's really proud. We have a really low turnover rate. It means our social workers are staying in place and actually building meaningful relationships with our residents, and actually that changes the way of care. Suddenly there is able to have conversations, people realise what's going wrong, and I think it's a really time testament to actually some of the really good work that we've moved to here in Thurrock. I know committee saw last month they did get a report for going out to commissioning for domiciliary care, looking at a new model for really get 10 years of actually how we're going to do this and how we adopt and work with providers to build human learning systems into that. I'm really pleased that went to Cabinet last month and is now going on to actually start kicking off that procurement process. So I'm sure the committee will be quite interested, given the big length and size of this contract, actually coming back and having a look as we go through that process. I'd just like to quickly point out, I'm sure members will be aware that there is CQC inspections that are happening now for adult social care departments. Ian and Les and the team have actually been working night and day trying to make sure Thurrock is fit and ready for when we eventually do have that call. We've gone through using the self-assessment tool and actually trying to build in to actually identify some of our strengths and weaknesses, and we're actually starting to pick up now, actually really identify when we do get that notification, how we actually do respond to that, and having the evidence base and having the cases ready to need. We're really good. We are picking out quite a lot of good ratings already that are coming out the self-assessment tool, and I will continue to prepare. It's one of those that we'll keep dreading about it. The first few have already been announced in January. I'm not expecting any more really before the election period. So it's just something really to keep on the radar, and it's actually one of those things that we are actually having to keep a focus on as we try and move forward with the service. I'm sure, as I say, Chair's probably said there's so much stuff in this portfolio report that members would go through, but do pick me up on stuff. I'll move quickly on to public health. And again, our public health team here in Thurrock are fantastic. That some of the work that they're doing is envious to other boroughs. Particularly some of their work they've done with CVD, cardiovascular disease. Thurrock was actually performing. In fact, I've got the measure here. If you bear with me, Chair, that we're actually looking at so that in terms of actually with some of the highest quality of primary care in six of the 12 measures, actually Thurrock in terms of position of hypertension management, heart failure management, and smoke status, that we're performing best, even though we actually have some of the longest GP lists in the country, and actually it's a testament to some of the work and how we're actually using our public health management data to actually try and predict what we can do and building some more preventative measures, working with primary care. Especially some of the other things that the public health team have been up to. We've gone through some procurement exercises, quite a few in terms of some of our services, substance misuse and sexual health, which are due to start imminently. With a new service looking at actually going into the community, actually really being there, actually much more, instead of having to go to specific places, actually getting into the libraries, getting into some areas where the community can touch base, and it makes it easier in terms of access. Equally, we are looking to go into a procurement process for our Healthy Family Service. We increased the budget envelope just to make sure that we're going through that procurement process back in January, and looking at really that really includes our school nursing and other things for what we're doing, especially the work with the family hubs we've got. The family hub program we've now got here in Thurrock. It's a fantastic bit of transformation funding we've got. And actually looking at building in some of the new services that we've got there and new access to opportunities, really making the public health team really making worth of that use as we go forward. And I'll quickly jump into the communities aspect of my portfolio, Chair, if you just bear with me for a little bit longer. Obviously, our community development team are doing, again, really great work in terms of actually looking at managing the health inequalities grants we got from the ICS and the Youth Choice event we've had for Chadwell and Tilbury PCN. That is some of the models of actually how we're doing to actually engage the community in picking what they want to fund and what they want to and what type of services they want to see is actually building into how we build the new operating model. I know Ian's looking at this and actually doing, again, working night and day than he normally is, that he normally does, trying to look at how these models work and actually getting the communities into actually starting to decide what services they want to see in their area. Members will note as well community impact assessments were brought in since December 22. I'm really pleased members are referring to it in reports. That's the first thing they're going to look at. They're looking at actually how does that inform the decision that they're making in terms of our communities, and I'm really pleased that they're being used. Chair, thank you for bearing with me as I just do a run through the report, but of course I'm more than happy to take questions from all members, anything in particular they want to know. Thank you.
Councillor Spate.
Firstly, let me say a heartfelt thank you, not just to yourself, but to the team. This is a really encouraging report. It's detailed, and the fact that you're here to present it is also very commendable. And it's sort of reflecting back on something that I was saying earlier on about wanting information. That's not necessarily, just to highlight everything that's not working, that's rubbish, that's negative. And it was quite interesting when we started to drill down into the Foundation Trust report. We actually found some really positive things for Thurrock to talk about. And we've talked about bringing staff to come to Thurrock. We talked about shortages in healthcare professionals who don't necessarily want to come to Thurrock. If we were singing and dancing and making all this information as well known as we could do, that would be an awful lot easier. And we'd cut down on some of these shortfalls. So I'm a curmudgeonly old git, always sat on the end of the table having a moan. But part of the reason for that is because when we've got good news, we want to shout about it. And I do think this report is really full of good stuff. I know there are going to be, and I know from Ofsted days, I know CQC is going to be the same. A lot of sleepless nights ahead for those people, and I don't envy you it at all. But and I'm sure I know because I've had conversations. There are areas that you're already concerned about, but the fact is you're doing the preparatory work, which is commendable. And I wish everybody concerned in it well. And who knows what will happen after May? But I would like to thank you, George. One thing that I have picked up on, and this came from, and I mentioned it on Tuesday night at Housing because it was the same thing, is our community-led ethos, where you've made great strides, and it's been particularly led by the teams in adult social care, but also when it's bled through into housing and whatever. There is a concern, from what I've picked up from conversations with members of staff who shall remain nameless, but basically the middle tier, that they're worried that we're going to lose some of that community-led initiative going forwards. And I would just hope that it's just a little bit of paranoia and fear because of change, because we have got a lot of change across directorates coming in. So my job is to listen and bring back information, and I think there is a fear within your departments that change could actually undo some of the great work that's been done. Your report identifies that great work. I commend you for it, and I'd just be proud of what you've done and tell the story as well. And I wish you luck with what's going to come. And I shall now shut up.
Thank you, Councillor Spate. I know you're always looking to praise some of the work the department does. The questions at full council back in September, and actually, especially as your response to when we did the briefing session for members, actually drilling into actually the interest of what some of the work, especially the preventative work we do. I'll just pick up really on your comments on the community-led thing. This is. It's not. For always, our red lines has always been we've done some amazing work here in Thurrock. We're envious of other places. Actually, some of the systems we've built and the outcomes we're now producing. I really like to give the staff reassurance. Well, yes, we are having a lot of change we're going through, and we're developing a new operating model. We're really wanting to build on what we've got. When we keep talking about we're worried about making changes or making cuts or anything. It's not. It's a question about best value, and we're delivering really high quality services here with our community teams and actually how they're built in. And
Just, isn't it funny we use words best value? Best value strikes the living fear into some people's hearts. I hate the words best value because it scares people because they always think cost cutting and chopping stuff down. So again, terminology is important. Sorry for interfering.
Apologies, Councillor. That wasn't in the intention of what the word. The problem is sometimes you get so bogged into the speech of when we talk about in terms of higher level and where we're getting to with the intervention. But that's not what I mean by that at all. And I'd like to thank you for being able to give me the chance to clarify that. No, the building of our community-led teams in the localities is completely changed the way we operate, and we need to continue to build on that.
Any other questions?
Yeah.
Councillor Polly?
I'd echo some of Councillor Spate's comments. I absolutely do welcome this report, and I've repeatedly praised our adult social care team and our children's services. And I remember during Social Work Week, we were one of the few areas where we had agency social workers come here, and it was really encouraging to hear that they've benchmarked, they've worked for other authorities. They haven't. We had homegrown talent within the mix, and then we've had other people that have worked in other areas, and they've chosen to come and work in Thurrock. And I think that's a testament to you know, the team and the team behind them. That when you and we've also had some peer reviews that have been outstanding and do hold Thurrock as an example. So that doesn't come without hard work. That doesn't come without people having a passion and a dedication to the people of Thurrock. You know, it's not always about numbers. You know, especially in this directorate, it is people. It's people-based, it's people-centred care, and that is what I've always known Thurrock to try and deliver for its residents. And I'm getting a bit emotional because I just think that, you know, we've got, I'd agree with Councillor Spate, we've got a lot in quite a negative situation to be proud of and to celebrate. So that's the compliment side. I also, on the housing side of it, the LACs and the financial inclusion officers, and during this recent, you know, cost of living crisis, they have been, when people have come to me for ward work, and I don't know where to direct them, and these teams of people, and I'd like to mention individuals, but they won't appreciate that because they all say they work together as a team, and people that are normally, you know, not self-serving are the people that do want to help the community. I was at a meeting at Bellis Library just this week where we had a community group that wanted to offer some services on a voluntary basis and that, and I was blown away to hear, and I have to expose my ignorance. I had no concept of the stuff that even with the digital world and that, like what we're trying to do to, you know, with the technical gap, you know, getting, there's people in libraries that if you don't know how to fill one of our online forms that council has many of, can assist you with that type of thing, and it was generational, from coding for young people to just being able to do a Zoom meeting with your granddaughter in Australia. You know, that it was an education for me, so I very much just want to celebrate all the good work. I have got a couple of questions on the partner report where you were saying about the work we've done with public health and cardiovascular services. Great news. Do you think that has been affected by the fact that we do have the PPCI at Basildon, that we have got, you know, a regional cardiothoracic centre within our midst, and we have got the extra clinic now at the IMC. Do you think geographically, because it is sort of quite prominent within our healthcare service, that message is easier for the GPs and public to access? Do you think that might be some of the reasons for our success?
Thank you, Councillor Pollen. Thank you for your comments. I think there is a bit of that. There is that we do benefit from that position, but actually some of the work that we're doing, particularly with the community side of it, is actually is our data-led side of that, and actually understanding we benefit from having the population health management team here, team based here from Mid and South Essex, who look at across the whole board of the spectrum. But actually, we've got some of the projects and work we're here doing, actually getting GPs involved with that process, and actually getting it changes the way. I had a conversation with another Essex member of Parliament who was very concerned by cardiology appointments at a hospital, and was actually starting to look at looking at the community. And first thing they got recommended was go talk to Thurrock. Like that's a really good thing that they're actually what the model we have got adopted here is demonstrated to have worked, and now other people want to use it. Like that, and that when we keep saying that we always worry about, we always got good news, and the chances when we do need to celebrate our successes, this is one, and it's a bit we benefit from those areas here, but actually we're adopting a method that is data led to actually understand the issue, that we can respond to it, and actually building around our PCNs and with our GPs in actually to roll out services that actually do work in the community.
I think Councillor Fish has a question.
It's not so much a question. It was just while people were talking about the good work of our social care department, I was reminiscing about when we became a unitary authority, and we actually set up our social care department for the very first time, and how exciting it was to be involved in that. And we wanted to do different things differently. That was our kind of motto in those days. And I think since that time, in the late 90s, we've continued to innovate, and we've continued to do things in a way that has achieved best value, not in the sense of cost cutting, but best value in the sense of working with service users to make sure that we provide a service that they are going to appreciate and is going to work for them. And I think of an example, the local area coordinators. When I was a portfolio holder in 2010, 2012, we introduced those officers, and I think they've been a huge success. And it was actually taking a bit of a chance at the time. We weren't sure how that was going to work out, but I think they've made a great contribution, and they continue to do so. So I commend the portfolio holder for the work he's doing, and I hope that continues in the future under whoever's leadership.
No, thank you, Councillor Fish. And yes, no, of course, I really welcome your comments. Just, I know Chair probably wants to start to wrap up slightly. I think that actually, I'm really pleased that the committee actually is. We're all on side here, and actually saying that work we're doing here in Thurrock is really good. And it's really testament to the officers beside me and the staff that work in the department. It's been an absolute pleasure. I've really enjoyed being someone who's not had a background in social care, coming into this, actually learning, getting on the ropes with my officers, actually understanding the issues, actually understanding the sector, and actually getting involved with the community and speaking to people. It's been really a really good year, and I'm really pleased this report has been welcomed.
Right. Thank you, Councillor. Councillor Cotshaw. I'd too like to thank the staff and the strategy, which I really do support and endorse. I think it's a really good strategy, but the proof of the pudding is going to be in the eating. Okay, so I'm not. I don't want to be the downer and stuff, but I think we're getting the structure, which isn't completely there yet, but we're getting the structure, in terms of the integrated teams, for example, and how well they work and how well the services actually deliver. And for me, we're still in the early days for that. So I look with interest from the customer feedback on how our services are delivered. But yes, thank you for the report. Really enjoyed it and reading it, and thank you for your work on this. Okay, Neil?
Yeah, just to comment, Chair. Councillor Cox, thank you ever so much for that report. And it's a fascinating reading for someone that was in the very early days of some of those developments. It's been fabulous to see how they've developed. I was particularly impressed to see arts and culture in there, because I think the bringing of them in there is absolutely critical. Obviously, you know I'm a fan of the Thameside complex. That's another debate for yourself. But in terms of the, I wanted to make a point about the theatre. The Thameside Young Producers, it's worth just mentioning them. I know you've met them. There's some excellent work they've done there with young people going into the community. And also the fact that we got, I was part of the consortium to get Arts Council money to 1.3 million for the START initiative, you know, the CPP money. They've been doing some really interesting tendering and commissioning with the community, leading the arts stuff that's happening in Thurrock, and it might be there's some learning that you could do, or certainly meet with them to think about that from your officers, which would be good. And finally, to say the good news very recently is our friends that you mentioned in the report from the LGBTQ plus community. There's going to be the first ever Pride March in Thurrock this year, which is amazing. They got Arts Council money and lottery funding, so you're very welcome to join us on that if you want.
If that's okay, I'd like to move on. Yes, thank you, George. Right, and of course, to help get that excellent CQC rating that we're hoping to get in Thurrock, we need to think about co-production.
Yeah.
Okay, so that brings us on to another agenda. Now, I think I wanted this originally on the work plan because I met a number of people with disabilities who spoke to me about co-production from different types of groups, be it mental health, learning disabilities and others. And so that's why I brought it to the committee. So I think, Les, are you reporting on this?
Indeed I am, yes.
Right, over to you then, Les.
Okay, bit difficult basking in the glow of all of that wonderful feedback, but it's worth saying, I think, that no social care department is always right or always getting everything right, and it's certainly true with co-production that you can never feel that you've completely cracked it, because it's a really difficult thing to embed throughout everything you do for a whole range of reasons that I won't take you through now. But to get to the report itself, we've set out here, I guess, two answers to the question. The first one is the way that we use the strategy and all of the values and principles that are in it, and the way that we work to deliver co-production in a sense at the most important point, which is the point of the relationship between us trying to support people and people who require some support. And I think often co-production is always seen as kind of big set piece things where you have, I know, a board set up, or you get people involved in the commissioning work, and or you have a big kind of engagement do, and of course that's important too. But I really strongly want to stress, picking up on what you've all said about the strategy, written throughout that strategy and the way that we approach work is on this notion of genuine power sharing between the people who are credentialed, the people who are paid to do a job, and the people who are requiring some form of care and support or advice. And so the first part of this report goes through that in some detail, going through the Better Care Together excuse me, strategy again, and showing a number of different ways that is manifest through that work that we do. And getting to CQC, I hope that they are convinced by that argument as well, because they tend to look for the kind of co-production I've talked about, which is the kind of second way of doing it. The big engagement pieces, the big consultation pieces, seeing people involved in some of the strategy and some of the decision making. So first part sets all that out, talks about the work we've done and gives you a case study to show that in action. The second part of the report then talks about the specific things that I've kind of alluded to, which is ways in which, as a social care department, we have included people, continue to include people in those strategic decision-making kind of areas like commissioning and like developing strategy over time. So have to reference here Natalie Smith's fantastic community development team. They're tiny and the amount of work they get through is incredible. And they've done a whole lot of work about how we can hear the voice of local people, respond directly to it. It's a great piece of experiment to use the human learning systems language in the recent participatory budgeting that they set up. Was very, very successful, and as you know, the ambition in the Better Care Together strategy is to move that out across all 4 PCN areas, which will effectively give us a economic framework within those local communities in which they have control over use of resource. They can bring and express their own priorities for wellbeing in that area, and we can provide funding so that money will be allocated through that kind of community investment approach, obviously linking in with things like the micro enterprise scheme, which has been fantastically successful in a whole range of ways, both supporting those people who deliver the service themselves, because one of the things I think was in some ways an unexpected benefit was the impact it has on the well-being of those people who start those micro enterprises and are able to give something back to the community and also get gainful employment often at the same time, and obviously the benefit that then sends out into that given community, because you have small bespoke type services that are very, very able to react to people on a one-to-one basis, and it creates the added economic value of ensuring that investment that the council makes is then generated throughout the local community and creates a kind of an economic good within that community itself. So I won't say too much more. The report, as I said, sets out all of the things that we've done, all of the things that we are doing. But I would say, again, to stress that point, we don't sit on our laurels. We know that there's much, much more to do to be truly able to develop that collaborative, joint power sharing relationship with individuals and communities, so that everybody contributes towards the kind of common good which is about improving the health and well-being of the folk of Thurrock over time.
Without wishing to sound old-fashioned, because I think I could be accused of this,
I'm sure
certainly before COVID hit, we used to have groups of people, often the same people in the same groups, saying things about how they'd like things improved or in their services. There is some value in it, but and I like the approach you're talking about, but is there some value in kind of taking that approach a little bit of the old-fashioned way and a little bit of the new way?
Absolutely. The partnership boards functioned brilliantly well until COVID hit, and then for obvious reasons we couldn't get together. And in fact, my old co-chair is here tonight, Anne White. We did. And it's fair to say that since COVID, but also the added upset of Ian Evans, who was a really big driving force behind those partnership boards, unfortunately passing away during the COVID period, has created a bit of a hiatus for us, and we're not yet back to that position. But we have our user-led organisation here represented as well tonight. They've been tasked with drawing up a new approach to delivering partnership boards, and also we had the what's it called, the Thurrock. It wasn't statutory. It was a nice to have, but we had one. The thing that we developed.
Local account.
Local account. Couldn't think of it. Also, we want to refresh that. So that was a sort of manifesto agreed between communities and the things that they deemed important, and us taking that seriously and delivering back to them in terms of meeting those principles. So something else we really want to refresh, because it worked quite well. We think that because things have changed, we will move, instead of having a centralised partnership board that meets quarterly in the beehive in the evening and was all encompassing. That can also be quite difficult for some people in terms of access, in terms of timing, and you tend then to get a fairly discreet group of people who always turn up, which is fantastic. I'm not in any way criticising that, but we're really anxious to make sure that we extend the voices out. So we want to build something that's far more localised on those 4 PCN areas, that replicates the integrated locality work that we're doing, and have a variety of different meeting times, meeting venues, so that we can ensure that if people want to come along and be part of that partnership board, we make it as easily accessible as we can. And that works now in train, and I did ask Gina tonight, and she said that by April she hopes to have a plan to deliver that.
Okay.
Thank you, Les. I just wanted to say something about the partnership board. So during the last 18 months since I came into post, a lot of relationship building has been done, and actually a lot of preparation for these partnership boards. So, you know, there are many people with lived experiences that we've started to kind of talk to about being part of these boards, and they will be more dynamic. So we are looking forward to getting those set up in the next few weeks. So we will report back and let you know what the progress is on that.
I look forward to that. This is something I'm very keen on. Okay, any questions? Councillor Spade.
Just this all sounds fantastic. Sort of looking through the small print on the report, Les, looking at risks that brings in finance, and interestingly says part of the risk with finance, if I'm paraphrasing it, is that we don't actually do what we're going to do, because that'll then, if we don't take things forward, that'll end up costing us more. So I do worry that there's so much scrutiny into every pound, shillings and pence in this council at the moment. I just hope that that we are on top of all that, and that we don't get frightened off. And I suppose I'm asking you to be brave. If an accountant comes in and says you shouldn't really be doing that because it's a bit risky, refer them back to this, where it says if we don't do it, the risk is even greater. We shouldn't be, at some point we're talking about green shoots of recovery in Thurrock. We've seen lots and lots of positive things in so many areas, and being a little bit negative thinking sometimes, I worry that somebody's going to come along and start putting the size 9s over things and stopping us doing it. And we've got, we've new finance teams coming in and new structures being there. So, just please continue to be brave. But also be aware that I think that ambition sometimes can be compromised by not being brave enough, and don't let finance stop us doing what I think looks really, really positive. And I'm sure that there'll be people like Neil and his teams and other people who'll come in and find ways to get around some of the problems that you might hit if we just sit inside a square box. Because thinking outside that box will get us a long, long, long way.
Okay, a few things really. Firstly, yes, bravery, and it's been important. This is this transformation journey is now 14 years old. As Tony Fish said, the LAC's coming in 2011, I think, so, and they were the first tranche of this big transformation. So we've been at it a long time. It's bravery, but it's also kind of the ability to stick at things when it seems like the whole world is kind of changing around you. And that's happened a few times since, because we've had COVID, we've had, I don't know, 3 restructures of the NHS, and you're dealing with different people overnight. We've had, all sorts of issues that have come at us, and we've just managed to stick at it and be kind of, I suppose it's almost dogmatic enough to just say that, you know, we think that what we're doing is right, and we're going to make it happen. So that's part of it. The other thing I'd say is, in terms of the finances, it's really difficult to be absolute, because obviously we understand we have a massive financial challenge, but because of the work we've done around prevention, and because of the work we continue to do in terms of managing the resource effectively, but always from the perspective of improving quality and improving casework, because we found out a long time ago that, ironically, doing the right thing is almost always the most economically viable thing. That we have managed our budget this year incredibly well, and I think as long as we continue to do that, then I think we've got every chance of being able to continue to resource this transformation journey we're on. And of course, that's not just us. You have to say a big thank you to our colleagues in the NHS, because locally, certainly, they've really come on board, and this is a whole systems transformation, and everybody is committed to it happening. We went through today the first year action plan, to pick up on Councillor Hooper's point, and I think we've probably delivered upwards of 90% of everything we set out to do. So you can never say never, but I'm as hopeful as I can be that we'll continue to do this.
Neil.
Yes, Chair, if that's okay, the group here asking me to read out a few bullet points that we put down about co-production. Be really quick, yeah? So is that okay, yeah? Cool. Okay, so for us, it's about a moment where our past and experience as experts by experience is respected. The people we speak to prefer equal value partnership. For them, this means we know things at the same time and are working on them together. We need to be at the beginning, not at the end. We need to have transparency. We need to have answers for the questions we give in order to go forwards. We need to see actions and things being done differently, and how have they improved. We need to agree what part we play and what part they play towards an agreed common goal where we become a we. We need to engage to agree what is the future we are working towards. We need to say, has there actually been any co-production since 2019, and we need to restart it how we left it pre-COVID. We need to produce co-produced equality impact statements, so that when you have to make really difficult financial decisions in the future, that those co-produced equality impact statements can really get the voice of the community heard when those changes are put to councillors. And we need to consider how we use co-production to support continuous improvement. That was the statement.
Les.
Can't disagree with any one of those statements. Absolutely right. And it just struck me sitting here, and this might be a silly idea, but it might be nice to have some kind of charter of co-production drawn up along those standards that we could all sign up to and all adhere to, because they are, you know, beyond argument, really.
Thank you, Les. I have bought a copy for you to take away with you.
Thank you. Right, are there any other questions? I'll move on. Oh, sorry, my apologies, I forgot Councillor Fish had a question.
Councillor Fish, you're on mute. Councillor Fish? Councillor Fish, you're on mute.
That's it. I'm unmuted now. I thought I'd done it before. Anyway, yeah, just listening to what Neil said, I found it quite moving actually, because again, when I was portfolio holder, we just started to introduce the concept of co-production, and I really pushed it with the officers that it should be a part of everything that we do. And what Neil was saying is really what I was trying to achieve. So it's really important to me as well as you, Chair.
Thank you, Tony. Unless there's anything else, I'd like to move on. But yeah, I think it's an idea if we have a charter.
I'll work on
Right. If I can move on then.
Blueprint there.
If I can move on then, I'll discuss advocacy and to include health watching. That's over to you, Kim.
Thank you, Chair. I think this is just something that's been bubbling on for a while, that there's some discontent throughout the communities around the provision of advocacy with voiceability. And I think some of it is around the understanding of it's a statutory service and there's statutory bits. But when you're trying to get somebody through that, it can be really, really difficult when you just get a blank, no, sorry, that's not within our remit, we don't do that. Because there isn't anywhere else for those people to go, and then we're stuck, they're stuck. The main bit that Health Watch deal with, apart from signposting, is around the NHS advocacy, which is part of that now. It used to be with a different organisation. And we don't do too badly, because we've now, after lots of toing and froing, we know what to write and how to write it. But if somebody out there is just trying to access that themselves, they're getting a knockback that it's not right, and it's really just the way they're wording things to fit into that service. Prime example, this week I've had a phone call from Rita, the carrier, who's sort of got out there. So she had a patient who wanted to make a complaint about her service. And she's tried to support this lady to get her some advocacy, because she said that she really does need some help to do it. And she got knocked back by voiceability to say that it's not an appropriate referral. So we've taken it into Health Watch. We got the consent from the person. We've now put it forward, and they've accepted it. So it's really hard when you have to find a way. And I know that from the coalition side, I know they've had lots of issues around the mental health advocacy, but that doesn't reach us. So I think you guys have got some to chip into it. I don't know what the answer is. It's about maybe there needs to be a really clear guidelines out there to say, this is what you must say, this is what we do, this is what we can't do. And when we get to this is what we can't do, where do we go? Because it's all in one place now. Who wants to take this one? Gina.
So yeah, just to back on from what Kim has said, as the coalition we do a lot of groundwork. We speak to many people with lived experiences and many people who require the support of advocacy. And actually on a very basic level, people don't know who is providing advocacy, they don't know where to go, they don't know where to get the information, they don't know, what they can be offered. So there is a real issue there in terms of that particular service that's being provided. I know that we've spoken to Thurrock and Brentwood Mind. Neil, I don't know if you want to go through the information that they've sent us in terms of advocacy as well.
Yeah, sure. So basically, what I think things have changed for them. They used to hold the contract. Just to be really clear, that when people get through to voiceability, there isn't an issue with the quality. No. I just wanted to state that because it sounded a bit like you thought there was. It's about how they get there. And what Thurrock and Brentwood Mind are saying is that basically there's a lot of. I think it might be something Les and I spoke about ages ago. It's the definition of advocacy. Yeah. What you've commissioned is very formal advocacy to look at quite serious things that are going to impact on people's lives. But what people are seeking is that informal stuff. And of course, in an ideal world, the LACs, the other things that you've put in place could cover that. So I don't know if there's a miscommunication with the community, not understanding that actually there is something called advocacy around, but it's not called advocacy, or there's something amiss, because Thurrock Mind are talking quite big numbers, like 243 people that were unable to get a service that they know of, over a year period. That's quite a large number, isn't it? You can, yeah, go on.
Okay, there's a couple of things here. The first thing is the contract is for statutory advocacy, but that doesn't prevent other people from having advocacy where there is a need, because it can be spot purchased. So it's not, and we have done so often in cases where they don't quite meet the criteria for a statutory, because that's around things like doles and MCAs. And so Voiceability, to be fair to them, was set up to deliver that statutory service, and that's what they deliver. But there is capacity to do other things if we are kind of informed. Having said that, if Voiceability are not responding appropriately, and therefore when Kim goes back they say, oh yes, because it's about the way you ask, then that's a contractual issue, and we need to know that, and we need to deal with Voiceability in terms of the contract management and saying, you know, you're making things difficult for people, and that shouldn't be happening. Yes, I appreciate there's some things you can't do, but this appears to be more about the approach than the definition. So we'd need those details, Kim, and we can pick that up through the contract. The third thing I would say, though, and Mind is a case in point. We've heard this anecdotally for a long time, and particularly from Mind and others, and we've said, give us the details, give us the data, and we can deal with that. We can look at the cases and we can decide what to do. And they never have. And that's been one of the issues, because if you don't know, you're dealing with anecdote, and it's impossible to do anything about that. So I suppose there's three issues. There's a contractual one. Kim, let us know that those cases, and we'll deal with that through the contract. There's also one about us probably needing to be clearer about the fact that there are other ways to get advocacy, and it tends to come through casework rather than through that kind of formal approach, and we maybe look at how we advertise that. But the third thing is, if there is a major problem, let us have the data and we'll look at it, and we never have had it.
Okay, can we get, is it worth asking Mind for that data then?
Yeah, absolutely. I mean, the more information we get, the more information we get, the better we're able to respond. So, absolutely.
Because a number of issues I get
Yeah.
mainly come from Mind. Okay, there are others as well. Okay, okay, that's actually really helpful. Councillor Foley?
It's just more a comment rather than a question. I mean, and very often I think advocacy is a word that isn't understood by many, but can mean many things to many people. So I absolutely agree with what Les has said and Health Watch, that with Kim, that it shouldn't just be, no, we can't do that. There should be then a signposting on, that's not our remit, but try these, they might be able to help you, because obviously that person needs a safety net. They wouldn't have contacted advocacy if they didn't feel vulnerable and unrepresented. So I absolutely agree with that. And that I concur with Les and with Chair that we need to see a little bit of a breakdown on that. Again, back to Councillor Spate's thing about drill down on the numbers and see if it can be identified where there's certain groups. We will, unfortunately, and I'm not, you always will get the odd one that where the issue, that person's issue can't be resolved, but that doesn't mean that they don't need help and support. And this is, you're going back to LACs and stuff, and that I think, and we've had this at previous meetings, EPUT last time, you know, the amount of people out there that are neurodivergent that have probably fell through the trap, you know, it wasn't identified till 2011, was it? So just coping with life, they've sort of fumbled their way through life, but they're getting to a stage where now they're getting overwhelmed with everything, and they've never been picked up. It's never been identified. So and I do see some of the work that's going on with our teams that is just helping people with some basic life skills, and as you say, then Liz, they go on to be volunteers, or they become peers for people going through the same problems, which is amazing, because that then puts so much pride back into them and gives them a sense of self-worth, and that feeling of like, oh, it's not just me, or it wasn't, there was a rationale. So, yes, I think it'd be really helpful not just to see numbers, but to try and sort of disseminate where the problem area is. Thank you.
Councillor Spade.
Yeah, interesting thing now that Les just said, and he used the phrase, we need to advertise it, which is, I don't mean necessarily by an advert, but getting messages across. And I'm a complete amateur at all this, and I'm a very simplistic person when I see things, but I see the front-facing side of the council, and I'm only talking about the council, is we don't really seem to commit to making a real public show of supporting people who need advocacy, and I suppose the prime example is downstairs, and this showcase atrium that we're supposed to have in here. Now, we used to have an entrance and a reception area to the council that still exists, that was much more suited to purpose. It had interview rooms, staff were able to come down and talk. We've almost got, and it's not just anecdotal, I've seen it happen. We've got people coming into this building for help, and there is no capacity to help them, and there's no mechanism to help them or guide them or whatever. And I know from speaking to Kim, some of them get shifted down the road, some of them get shifted down to Ian and his team and whatever. And that's great, because I know they'll at least get some help when they do get there. But I really think it has to be, it's only going to be a very small brick of this advocacy house that we're building. But let's really commit to it. I really, really hope that we never stick a museum and whatever it is in that bit of a building, the other side over there. And if we don't do that, then let's use that suite that we've got for something that it could be really, really good. With some of the advocacy services that we've had, and I'm going to be really insulting, and I don't mean to be, we've stuck them in shabby shops and poor shop frontages in different parts of the town. And we're not saying, I think that undermines the importance of it. It really does. They get stuck in, in places where they're not at the forefront. Let's be proud of the fact that we recognise that people need support, they need help, they need good advice, they need advocacy, that strange word that covers a multitude of things. And again, as the administration going forward, whatever shape or form it may be, let's not be embarrassed by the fact that we've got people who need help, and let's help them, and let's make it a really public show that they're welcome, because really, that's a classic case in point downstairs. It's just not a welcoming place. If you're in need, you walk through them doors, do you really feel that you're going to get your need met? Because I don't think you
do. Okay, well, thank you, Councillor Spate, and I think that's something we need to look at. Thank you. Right, are you happy for me to move on? Yes, no. I'm aware of the time, and I said I'd finish at 9:30. I may need to run over by 5 minutes. Are you happy if we just run over by 5 minutes?
Sure.
Yes. I wanted to add to the agenda, but I'm not sure we're going to have time, but I'll tell you what I've done, okay? Because I did write for a request of information regarding people with learning disabilities annual health checks. I got a response. I actually wrote in June, but I didn't get a response till January, I don't think. I believe there's a record of 648 people with a learning disability in Thurrock. I think that should be a higher number, but that's the number we've got. And the records suggest that 408 people have had an annual health check. For me, that's failure. The average age of people passing away with a learning disability is 57. And the reason I have the annual health checks is to try and alleviate things that are slipping. So what I've done is today I've written to Alex Meekan, asking for a response to that information, what they're basically going to be doing about it. Now, maybe about holding GPs more accountable, but I want a response because I think this is actually outrageous. And I'm happy to share that response with all members of the committee and whoever's going to be on People's, because I do not want to let this one go. Okay? And as I'm a councillor, I will not be letting it go. Okay? So I'll wait for a response from Alex Meekan. I'm sorry I couldn't give it the time I wanted to today. Councillor Fish?
Just going to respond to what you said by saying that this has been an issue for many, many years. And I was really hoping that we'd made progress. I do remember being at a meeting of the Health and Wellbeing Board with Kim from Health Watch, and she was the first person who raised this at the Health and Wellbeing Board. And we had all the people around the table who could actually do something to try and resolve the issue. So, and sadly, even that hasn't worked.
Neil. Thank you, Councillor Fish.
Thank you, Tony, for that memory from the past. Just to say, because you kind of glossed over it, the average life expectancy is 57, guys. Just sit here and think. Some of us are over 57. A few people are under it, dare I suggest. But, you know, that is so incredibly young. We're a first world country. What on earth is going on? And secondly, to say, actually, this could be our first example of co-producing a solution. Because for us, we want to look at this as a wicked issue. We want to come together with health, who aren't in this room at this moment, and other people and yourselves, and say, let's try and work out who. It's not all for the NHS to solve. We know this. It's all of us in community to do our bit and try and come together. And it could be something where we come together, call it a wicked issue, because that's what it is. Let's try and see what we can do. I believe I've read recently the new targets for health are still only about 75%, which if you think about it, that still leaves 1 in 4 without a check, you know. And so we do need to look at it as soon as we can. And as I say, my offer is to say we will gather the right people in a room to do some co-production on this, to say, right, what can we all do?
That sounds a really good idea, Neil. Ian?
Yeah, I wholeheartedly support that as well. You're right, it's not, although it falls under the auspices of GP practices, it's a whole system, it's a wicked issue, and I wholeheartedly support what you've just said in terms of the level of health inequality faced by people with LD is frightening and unacceptable. This did briefly come up at our Better Care Together Thurrock executive this morning. The clinical director for Thurrock, and what I'm about to say doesn't in any way undermine what I've just said, but she was suggesting there had been a data issue where someone at NHS England nationally had pressed a button and it had recalculated all the practices denominators, and they were finding that they had coding of people who clearly weren't LD within the LD denominator. So I think there is something about trying to just make sure as a starting point the data is correct, and we've offered to support. We did, it was before COVID, but it wasn't long before COVID, and CCG days have a real push on this. And we employed LD nurses, and we worked collaboratively with the CCG in terms of cross-referencing our data with their data to try and get this right. And it had a really positive effect. So I'd personally be really disappointed if it had slipped back to the proportions that these figures are suggesting, and it may well have done so. So I don't want to decry the seriousness of the issue, but I think as a starting point, let's just be clear what the data is saying.
Okay. Ian, I completely respect your interest in data, but to be honest, we've heard that for 15 years. It's always a data issue every time, and I'm bored of that. I can probably name 200 people with learning disabilities that could do with some support in this area, myself personally, for who we work with. Let's just crack on. I actually don't care about the data in that respect. So, because every time it gets close, they will say, oh, but there's miscoding. Oh, there's people with different issues than learning disabilities that are in there. Whatever. You know, we're small enough in Thurrock, and our community cares enough about the people that live there that I honestly believe they will help us to identify people if necessary, that we can just crack on and see what the barriers really are and start lowering them.
Les.
Just very briefly, me and Neil have been around this block for so many years. I made exactly the same point today to Alex and said, we did it once before. We sat our nurses alongside you and we went through and cleansed all the data. You're right, the numbers are still too low, but we got close. And I made the offer to do the same thing again.
Okay, I guess from my point of view, you virtually cracked it once, we'll be back here again. But I do think we need to push this, and I'll be doing what I can to help. Thank you. Right, if it's okay, I'll move on. This is our last meeting. So I just thought I'd do a quick reflection on some of the things we've looked at over the last year. I'll start with the negative, if I may. We spent a lot of time looking at the integrated medical centres. I think people could have been honest with us a bit earlier, rather than we spent 3 meetings looking at this subject. I'm sure all of us on the panel are disappointed that we have not got the medical centres we thought we were going to get. I think the other thing that's disappointing is we didn't have the opportunity to do the work groups we wanted to do. That's primarily because we couldn't get support to the kind of healthier staff, obesity, and looking at mental health services. On a positive note, I think we've done some really good work in talking to Basson Hospital about the CQC reports and about trying to hold them to account and how they can improve their services. I think we got a really positive report on safeguarding and the safeguarding strategy, which I think was really impressive. And also the annual complaints, I thought was also a very impressive report. I think it set a good standard, actually. We started having updates from Fiona Ryan, so that's on the agenda regularly now, which I think is really, really helpful. We had a report on general practice, GP practices, which is really helpful in identifying maybe GP services that aren't working as well, and I really would like to follow that up at a later date to see if those services are actually improving. There were some really good services and some not so good. I think one of our biggest successes as a committee is we've held people to account in terms of blood testing. And I think it's an all-party approach in trying to resolve that issue. And I think we've gone from 8 weeks down to 2 to 3 weeks, so I think that is success. We had a very honest report from EPUT, which I really value that honesty. They're not in a great place, but they are working hard to put that right. And I would do all we can to support EPUT with the work that they're doing. And obviously we've had the reports today on dentistry and some of the other issues. I won't go through the agenda today. I would like to thank all the guests for their contributions. I'd like to thank all the officers for their contributions to this meeting and the reports they prepared. And I'd like to thank all the councillors for their contribution. I have really valued your contribution, and I hope I've been a fair share to you all. But on that note, unless anyone else wants to say anything. Georgette?
Thank you, Chair. I'd also like to thank Councillor Glendy for his contribution to the committee, but he'll be standing down this May, so whatever happens, we won't see him back in this chamber next year, but never say never, eh, Councillor Handy, let's hope you join us again sometime. But it is something I'm very passionate about. It's my day job as well as my and mental health services especially is something that is very dear to my heart. I can't known these guys a little while now, both in my previous tenure and as a returning officer, and as Ian said at the last meeting, you know, his continuity, holding some of these people to account is invaluable, the same as Neil. I mean, you've been around the block as long as I have, so yeah. And on that note, Chair, I do think this, as a new chair, you've done quite well. So thank you.
Praise indeed.
Councillor Spade.
Yeah, just to round things off, I mean, I've had 10 months on this committee when I came on it, and I'd no idea, really, about what I was getting into, and I've been an outsider looking in, and to some degree I'm now an insider looking out. And I'd just like to say the highlight for me of the year was, and thank God it served some purpose, was at Corringham IMC when we had a briefing evening, when we had all sorts of people in the room, NELFT and lots and lots of different organisations all coming together. And if one night summed up how you can achieve things, it was that night, because everybody admired what everybody else was doing, everybody shared ideas, and I think everybody who was at that meeting, and especially me, came out of it in such a positive frame of mind. And if that ethos carries through to the next civic year, then we will continue these green shoots of recovery. And I personally would like to thank everybody, officers and fellow councillors. I think we're a difficult pain in the ass to work with, but I've learned an awful lot from you, and I hope that we all go on this journey for a bit longer.
Thank you. With that, I'll declare the meeting closed.